is not on.
Oh,
It just
I don't
keeps
know
shutting
either.
off.
Yeah,
Wonder why it won't stay on.
I don't know. That was that way yesterday too.
Odd. I'm no help to you.
Yeah, that's why we will see. We're not doing additional.
Are you testifying in another meeting?
Going to be moved for more.
I'd like to.
And the way this-
Hi, Claire.
Good morning, Doc.
And the university was supposed to.
Morning.
That's up to the vice chair.
Madam Chairman, I believe we have a quorum, so we could go ahead and begin. Would you like to call roll now, please?
Yes, Mr. Vice Chairman. Representatives Clifford.
Here.
Connolly. Flitner. Ottman. Martinez. Stivar.
Present.
Wharf excused. Madam Chairman
Here.
and Mr. Vice Chairman.
Here.
Okay, we have 8 present, 1 excused.
So with that, Madam Chairman, you are our sole sponsor of a bill, House Bill 217. Would you care to go ahead and present the bill?
I will. Thank you, members of the committee. It's quite nice to see you all from this side and see all your happy faces, and rather than the side of your ear, which is the view I usually get. So House Bill 217, Community Health Center and Rural Health Clinic grants. I'll give you a little origin on this because some of you might say, I think we've seen this bill before, and you would be right, but seeing as there's a lot of new people, maybe not all of you have seen it. So the concept of this bill dates back to in the spring. You remember we had the special session to disperse CARES Act money. And then leadership asked the committees to come together and see what sort of other bills we might need for the emergency situation for a second special session. However, as you know, that second special session didn't happen. But what we thought of at the time in the Labor Committee during the interim there was the first special session, we passed a number of large bills. And one of them was basically funneling all the CARES Act money through SLIB. And those of us on the committee thought there are a lot of smaller clinics, healthcare places around the state that don't need large sums. They might only want $25,000, $50,000. And why crowd SLIB with all this work? Because there was an existing program. I mean, there is an existing program, this Rural Health Clinic Grant Program in statute that the Office of Rural Health, well, it was no longer funded, but it was still on statute. An Office of Rural Health was accustomed to working with the clinics and if we had money, dispersing grants. So we thought, why not channel some of that money through this existing program, save SLIB a lot of work, let it be done in a place that's familiar with the needs of small clinics for poor people, and it'll be great. Of course, as I say, as it happened, we didn't end up having the second session. In the course of drafting that initial legislation, though, we also discovered that the existing statutory program is due to sunset this summer. So, so what this bill does is basically 3 things, and I'll come to that in a second. But so let's just point out, this is a program that was started in 2011. And the legislature put $1 million in a program to give grants to small community health centers, rural health clinics, clinics that have a focus on the underserved, poor people. And Bonnie, did you distribute the list?
Yes.
Okay, so I gave you all a list of the clinics that fall under this category. So you can, everybody likes to look and see what's by them. So couple of, there's really only three, and I will also say, so we drafted that as a committee bill for this year. Let's take away the sunset date, so that the program can extend, even though, as I say, it hasn't been funded for quite a number of years. But it's still there on the list. And to be able to channel some money, if there were more CARES 2 or whatever you want to call it. So the bill started in the Senate, and to be honest, it didn't make it through the Senate committee a couple of weeks ago because there was some confusion about the bill. They're as new as we are. And the committee, to be honest, got a little confused with hospital funding through CARES Act, where hospitals were or were not getting money to do capital construction. And so the bill ended up failing because people got all this hospital stuff in their head thinking about this bill. And when I heard that it died, I'm like, what? Who can vote against clinics for poor rural people? I mean, how could that happen? So I listened to the audio, the YouTube of it, and realized what had happened. And I've reached out to people on the Senate side. So if you look at the bill, you'll actually see one of the no votes is now a co-sponsor. Youngsters, new folks, that's how things, that's how you can make things work. Reach out to co-sponsors, find out what their problems were, and go forward. So that's kind of the 30,000 foot look at this. So the purpose of the bill, there's basically three purposes of the existing program and statute. One is to delete the sunset clause. And right now there's no funds, there's no appropriation in the bill because I'm not appropriating any money. It's just to make the structure continue. So if we're ever rich again as a state, we could give grants, whether that happens or not, to federal dollars, and that's in existing language. They can take federal dollars, which does actually often happen, that there's federal, whether it's CARES specific, and I deleted the CARES specific language at the request of one of the Senate co-sponsors. His statement was, if we mention CARES Act, the pandemic will never go away because we'll always be wanting to have CARES Acts. So it just leaves the existing language about federal dollars. There's nothing changed on that. The third thing that is in existing language, but I think is really valuable in this time, they can also run foundations or charitable donations through the state program. So, and I can use names of organizations here, which I won't be able to do on the floor, but now you don't need this bill. Say your local Kiwanis or Rotary wants to donate $10,000 for some equipment. They don't need this program. They can just go to their local clinic and say, hey, congratulations, we're giving you $10,000, little ribbon cutting ceremony, photo op, that's it. But there are quite a number of national level foundations. And frankly, I don't know if it's just me or as chairman, I get emails from these people all the time. So places like Helmsley Foundation, Robert Wood Johnson, Ford Foundation, Pew, organizations like that, they have a lot of projects, and many of them are focused specifically on rural health. I'm not giving you a paper on this because we have too many pieces of paper anyway, but for an example, this is one that just came out last month. As the nation celebrates American Heart Month, a trustee for the Helmsley Charitable Trust talks about the more than $135 million that Helmsley's rural healthcare program has granted to improve cardiac care. And they gave AEDs to law enforcement and first responder and so on. I mean, it's, the specifics of the program are not that important. But in Iowa, they ran the money through the Iowa Department of Public Health. And in North Dakota, they ran $4.3 million through the North Dakota Department of Public Health to supply AEDs, those, if you have a heart attack, to local, state, tribal, and federal North Dakota agencies. So if the foundations want to give money more broadly, they can run it through a state program and disperse it that way. So I really see a value in that. So as I say, delete the sunset clause so we can distribute the monies. The second thing that I've done is I've added equipment to the allowable expenditures. If you look, and I will go over the bill, but it's not a very long bill. On the bottom of page 1, line 13, you can see the header of that title 92127. You can't tell because it's a header, but that word on line 13 are the words "and equipment costs" are new. Currently, the statute just says facilitating capital construction and startup costs. Thinking back to when the bill was first came into statute in 2011, they were thinking of startup costs. But realistically, we don't just need capital construction. I mean, we don't necessarily need to build on a wing. A lot of places, what they might need and would be telehealth equipment, IT type things, or equipment that they can rent out to patients who are maybe post-operative and live out on a ranch. And if you could loan them out some sort of monitoring thing for a month and then take it back. I mean, that kind of thing. So that's why I've put in equipment, because I do think that equipment is equally, if not more valuable than just some sort of capital thing. So that's the adding equipment to the allowable expenditures. And then third, and Mr. Chairman, maybe I'll actually start with the bill so you can see where the third comes in. Page 1, be it enacted and all that sort of stuff, just the change of the adding in the equipment. The top of page 2, there's created a process. You can see on line 3, I've added in the equipment. Process should be administered by the Department of Health, and it just tightens up a bit, awarding grants. Okay, now the B that is skipped, that of course we're not changing it so you don't see it, creates the primary care support account and says that they can accept federal money, gifts, transfers, bequests, donations, and such like. That's very standard language. So C just adds in, because I changed the subsection D and the C. D, now here's a part where there's a change, and this is the third point. In paragraph D on page 2, any grants provided by the department under this section that are funded in whole or in part with state funds shall be subject to the following. So then we have a bunch of things, and you only see the 2 here, but what is in statute is, and keeping in mind that when this program started up in 2011, it was specifically really they were thinking of state grants, that the application had to be approved by the county commissioners of the local community. Then we have the bit about startup costs and such like. Then it had grants not exceeding $1 million of state funds. Grant applications had to show a commitment of matching funds, that they should provide services to the public regardless of ability to pay, which actually is, you'll see that's coming up on page 3 just because of adding a line. So what I'm doing here in the bill is just specifying on line 17 that if we're talking state funds, those restrictions still apply. So I'm not taking away the restrictions on going to county commissioners and matching funds, but I'm saying that only applies if the grants are for state funds. If the Helmsley Foundation, let's just say, wanted to have a program to give out telehealth equipment, that the restrictions on their grants are up to the Helmsley Foundation and these clinics. These are not state agencies, these clinics. These are nonprofit type clinics. So I don't see that the state has any role in putting restrictions on a nonprofit clinic and some donor as to what they can do. So that's right. So as I say, the existing restrictions are there, but I've just clarified that those restrictions only apply to the state funds, which just seemed to me to make sense. So then on page 3, you can see the top of page 3, we've added in the equipment costs. And then on line 11, there's 2 repealers. The 92127D5, the repealer there is something that says in current statute, grant applicants shall provide proof of designation as a rural health clinic or federally qualified community health center. And I'm taking that out, not because I want grants to go to, the movie star health clinic in Jackson or some sort of thing like that. We still have existing language that it has to be focused on, or they have to show focus on underserved and that kind of thing. But mainly, when you consider what federal qualifications there might be for programs from 2011. We have some other categories now. I mean, they have what they call FQHC lookalikes, various other things. I didn't see any sense to tie ourselves to some, decade-old language about what clinics for poor people are. So the requirement that these clinics still provide services to underserved is still in existing language. That does not go away. And then the G repealer, that's the sunset. So taking off the sunset entirely, personally. And let me just speak to that because I had some discussion with some other folks. The program has been in twice with a 5-year set. I am very much in favor of taking off the sunset entirely for 2 reasons. One is it seems very unlikely to me that the need for support for rural and services to the underserved will ever go away. I mean, that doesn't seem to be likely. And the other thing is that a lot of these granting foundations, they'll give you, say, a 2-year or a 3-year grant, right? Well, if you think about this program in statute, let's just talk about the one now expiring in 2021. If I were at a Pew Foundation or Helmsley last year and I've got a big wad of money to give out for, say, telehealth equipment, if an application comes in from Wyoming and we have to say, well, actually our program sunsets next year. I mean, why are you going to give out a 3-year project to them? It doesn't make, it'd be silly. So it seems to me that it's just tying the hands for our ability to receive longer term grants. And I don't see any reason for that. So, Mr. Chairman, that's my explanation, and I'd be glad to provide answers, hopefully.
Thank
Or
you,
I
Madam
know
Chairman,
there
for
are a
that
few
very
people
excellent
behind me.
review of this bill. Does anybody on the committee have a question for the chairman? Okay, I would say Representative Ockman has a question.
Thank you, Mr. Chairman. Representative, I was wondering, with these, just because I'm not real familiar with all of the rules for rural health, with these, say a donor does give a grant for 3 years, okay, and it's set up and put into place and there's people servicing it. At the end of that 3-year grant, then is it up to that rural health center to find funding to continue, or somehow would the state be responsible?
Mr. Chairman, the rural health clinics and these FQHCs are all independent. The FQHCs have community boards. They have no actual governance tie to the state at all. So they run their own finances that we are not in any way responsible for their fiscal situation, really. And as I say, this bill has no appropriation in it. As far as I know, right now, the program has no money in it. They used up their money, and about 4 years ago, since then we've been broke and there's been no more money. I just think it's a valuable structure to have in place.
Any further questions for the Madam Chairman? Don't see any.
Mr. Chairman, I'm pretty sure there are some people behind me who would like to testify, so I will move over then. Unless you had a question, beg your pardon, Mr. Chairman. It's hard to stop chairing even when you're here.
Thank you, Madam Chairman. Is anybody here in the audience that would like to? All right, if you step forward and have a seat. Give us your thoughts.
Sorry, just assembling the furniture here.
Everybody online?
Online too. I'll do them later.
Mr. Chairman,
Good morning.
good morning. I'm Jan Cartwright. I'm the Executive Director of the Wyoming Primary Care Association. I want to thank the committee for this opportunity to speak with you today about House Bill 217. And I also want to thank the sponsor, Madam Chairman, and the co-sponsors. I will focus most of my remarks on the community health centers that my organization represents. They are part of the healthcare safety net that includes rural health clinics and free clinics in Wyoming. Health centers, also known as federally qualified health centers, or FQHCs for short, provide healthcare for people regardless of their insurance status or ability to pay for their care. FQHCs won't turn anyone away. You can see, and I did share a handout, and I'm sorry I brought it late, but once you see that, you can see from the information that we shared today that community health centers save the healthcare system $56 million in 2019, including $15 million in savings to Medicaid. FQHCs do this by providing appropriate primary care at the appropriate time and keeping people out of the emergency room. Wyoming Health Centers provided care to 39,000 people, your fellow citizens, in 2019. Health centers also provide quality care. Most sites are patient-centered medical home designated. The 12th Street Clinic in Casper was one of only 200 health centers across the country to receive a Health Center Quality Award in 2019. 12th Street, along with the Crossroads Clinic in Cheyenne, provide care specifically to people who are homeless. And next week, Crossroads Clinic will begin receiving vaccines directly from the manufacturer to give to their homeless populations and others in the community. The bill today amends legislation, as Chairman Wilson said, from 2011 that was sponsored by former members of this committee. It was a joint Labor, Health, and Social Services Committee bill, I'm proud to say. The original $1 million was successful in helping 4 different communities, including the Powell Healthcare Coalition. They were able to compete for and win new health center funding, which is a national competition, in 2014. Today, they are known as the Heritage Health Center. They serve the Grable community as well as Powell, and they are a strong partner to the hospital and the school district. Community health centers are the workhorses in their communities, and they do it without any ongoing state funding. And even though the state cannot currently provide additional funding, this bill deletes the sunset date so that when the economy improves, health centers and rural health clinics will have the statute that supports their work. Thank you, Mr. Chairman.
Thank you, Ms. Cartwright. Does anyone have a question for Ms. Cartwright? See none. Thank you.
Thank you.
Any other testimony from the audience? Okay, seeing none, I'm going to close the testimony from here, but we'll go to the internet and get, do we have anybody there who wants to address the committee?
Mr. Chairman, I have Stephanie Pyle from the Wyoming Department of Health. I'll admit her.
Yes, please do so.
Good morning, committee members. Mr. Chairman, can you all hear me?
Yes, good morning.
Good morning, everyone. Mr. Chairman, Stephanie Pyle, I'm the Senior Administrator of the Public Health Division in the Wyoming Department of Health. It's nice to see you all, and it's nice to meet the new committee members virtually. I will be very brief this morning in my remarks. I just wanted to let the committee know the department has no concerns with this bill, and we appreciate the updated language. You've heard a lot about the way the program functions, and I appreciate Chairman Wilson's summary. As she indicated, this does open up opportunities if and when additional funding becomes available in the future, specifically federal funds. And we think that could potentially be a great benefit to some of our providers out in the communities. And I just want to give a special shout out and recognition to our rural health program. They really do find ways to maximize the resources that the program has to benefit your communities. And again, we have no concerns with the language in this bill and appreciate the updated wording to the statute. So with that, I'll be happy to stand for any questions. Thank you.
Thank you, Ms. Pyle. Does anyone have questions for Ms. Pyle? Seeing none. Thank you very much for your testimony.
Thank you, Mr. Chairman.
Mr. Chairman, we don't have anyone else in the Zoom waiting room.
Well, thank you very kindly. We got a short committee. Does anybody have any amendments for this? Or does anybody want to move the bill?
I'll move the bill.
A second? That's moved by Stivar and seconded by Ottman, amongst others. Any amendments to this bill? Stivar, Representative Stivar.
No amendments.
No amendment?
I just want to give Chairman Wilson a bad time. Put a sunset date back in.
Okay, I don't see any amendments. Does anybody have any comments on this bill? Representative Conley has a comment.
Thank you, Madam Chairman, and just a thank you to the good chair of the committee for going over and taking care of this with the Senate and bringing it back so that we can get it passed. There was a part of me that wanted to muck with it just a little bit. I wanted some personnel in there. I mean, honestly, to take care of the equipment. And it's like, not touching it. You've done a beautiful job. Thank you so much.
Any other comments or? All right, I guess the committee may be ready for the question. Go ahead and call the question.
Representatives Clifford,
Aye.
Connolly, Flitner,
Aye.
Ottman, Martinez,
Aye.
Stivar.
Aye.
Representative Worf left, I vote, Mr. Chairman. Madam Chairman Wilson. And Mr. Vice Chairman Hallinan.
Aye,
We have 9 ayes, sir.
we have a unanimous committee. With that, I guess we can
Well done.
say the bill has passed the committee. And the meeting is over.